Good evening, everyone. My name's Ashwin Venkatesh, and I'm the NANSIG educational lead. I'd like to take this moment to welcome you all to the first of NANSIG's new webinar series, Neurosurgical Career Insights, where we aim to provide medical students and junior doctors with an overview of what a career in neurosurgery entails. I'm just going to share with you my brief PowerPoint. So the aim for today is to start with an introductory talk on what is neurosurgery. And following this, we hope to cover all the bases and subspecialties within neurosurgery with guest speakers who are experts in their field, ultimately so that you can make an informed career decision. To this end, it is my pleasure to introduce today Mr. Ibrahim Jalloh, who is a consultant adult and pediatric neurosurgeon here in Cambridge. He specializes in brain tumor and spinal surgery. Mr. Jalloh was awarded the World Federation of Neurosurgical Society's Young Neurosurgeon of the Year Award in 2017, and his main research interests lie in energy metabolism in the context of neurotrauma. Just a few housekeeping tips before we begin, just to minimize any disruptions. Please could you all remain muted and have your webcams turned off at all times. And please could you direct any questions to the chat function, and I'll be making a list of the questions that you come up with for our interactive Q&A at the end, which should be about 10 to 15 minutes, just at the end of the talk. So that's it from me. Thank you everyone for joining, and over to you, Mr. Jalloh.
That's perfect. Ashwin, thank you so much for the introduction. It's a real honor, a real pleasure to be able to give this talk. I didn't realize there'd be so many people on it, so that's really good. So I'll get straight into it. As Ashwin said, so I'm a consultant adult and pediatric neurosurgeon here in Cambridge. I was appointed in 2018, but spent a few years training here and doing my research, and also trained in Nottingham, and did various SHO jobs around the UK and London and various places before that. So what is neurosurgery? So I think there are various ways in which you can answer this question, what is neurosurgery? I think in its modern iteration, it's a relatively young specialty that really developed after improvements in anesthesia, improvements in sterility, allowed safe, well actually not really safe, but allowed non-fatal cranial surgery. And that occurred at the turn of the last century. And then things really developed in the latter half of the 20th century with the arrival of proper illumination and the operating microscope. I won't spend too much time dwelling today on the kind of history of neurosurgery, because I think you can pick up a lot of that from the internet or books. And I suppose to begin with, the simplest definition of neurosurgery, I would consider safe surgery of structural lesions that affect the brain or spinal cord. But I think this question encompasses some other, maybe perhaps more relevant questions, such as what does a neurosurgeon do from day to day? Who is involved in providing neurosurgical care? What cases, what surgical cases characterize neurosurgery? And what characters, who are the personality types that end up doing neurosurgery? I think probably the easiest way to start with this question is to break neurosurgery down into its constituent subspecialties. So if we begin with vascular, so vascular involves the surgical management of subarachnoid hemorrhage, of aneurysms, of arteriovenous malformation. So the stereotyped cases for a vascular surgeon. I think the essential components of vascular neurosurgery is that often patients in the acute stage can be relatively sick, and so it involves patients on ITU. The other aspect that is particular to vascular surgery is about risk evaluation. So trying to decide whether somebody's risk of intervention, be that surgery or endovascular treatment, is greater than the risk of hemorrhage or pathology from the vascular malformation. Vascular neurosurgery is characterized by what I describe anatomy of discernible structures. So anatomy of structures that you can name. So it's defined by the knowledge, obviously, of vascular anatomy. And really, as a vascular surgeon, you need to be able to recognize the course, understand the areas that the vessels supply. All the blood vessels travel through the basal system, so vascular surgeons will have a very good understanding of cisternal anatomy and the relationship of the skull and brain to these different vessels. I think common to many neurosurgical procedures, and this is true very much of vascular surgery, is that it involves operating usually through a relatively small window into a deep location in the brain. And through that deep location, through that small window, being able to identify the structures. And I always think it's akin to, for example, being lost in Tokyo, not understanding the road signs, but being able to still identify your exact location based on the shape of the road and the arrangement of the junctions. So vascular surgeons will have a very good knowledge of the blood vessels from lots of different orientations through a small window. I think that's one of the features that characterizes vascular neurosurgery. The other aspect about vascular neurosurgery is that it's the one specialty where I think you really need a cool head to deal with a rapidly changing situation intraoperatively when a vessel ruptures, for example. So moving on, skull base can be pretty much divided into anterior skull base, lateral skull base, and general skull base cases. So in anterior skull base, the typical cases are pituitary tumors, and they're usually relatively short cases, maybe a couple of hours, and often they involve cooperating with an ENT colleague for endovascular surgery. Lateral skull base is characterized by acoustic neuroma surgery. General skull base is really for the most part, the surgery of meningiomas of the skull base. And those can involve quite long operations. And again, it's all about discernible anatomy. It's about recognizing structures in relation to the brain, in relation to into the skull base. Skull base surgeons, for example, love to be able to name all the triangles in the cavernous triangle. So that's skull base. Oncology surgery. So oncology neurosurgery is a different set of skills. And really oncology surgery, because there's no discernible, easily landmarked anatomy as you get vascular and skull-based surgery, oncology surgery, so I'd call it here imaginary anatomy. You can't rely on stereotyped anatomy, so it's very easy to get lost in the brain. There are no landmarks when you're resecting a tumor from within the brain substance. So really, glioma surgery is all about making a judgment based on the information that you've got. So I think glioma surgeons are really like politicians or a judge. They hear the evidence from the witnesses, they hear the arguments from the lawyers, and they use tumor to resect. And that information from the witnesses, from the lawyers, comes from lots of adjuncts, for example, using 5-ALA, which allows gliomas to fluoresce, so high-grade gliomas fluoresce using an oral solution. The patients take an oral solution of 5-ALA a few hours before surgery. We use a lot of electrophysiological monitoring to map different areas of the brain, and that includes both asleep and awake neurosurgery. We rely on the imaging, and even the imaging is a judgment call. Do you resect just the enhancing bit of tumor? Do you consider the flare signal change around this mass to be, to be part of the tumor as well? And then intraoperative image guidance, intraoperative ultrasounds, and more recently, intraoperative MRI. So this is the intraoperative MRI suite at the Walton Centre in Liverpool, and that's really useful for gliomas. And glioma surgery, as I said, it's really about making a judgment based on the evidence that's in front of you. So that's oncology. Functional neurosurgery is typified by pain and movement disorders. So all functional neurosurgeons are obsessed with neural pathways in the brain. as opposed to the other subspecialties, I think functional neurosurgery is very much about surgery on non-structural lesions. You're not taking out a tumor. You can't look at the post-operative scan necessarily to give you an indication of your outcome. So it's very much functional outcome driven. You're looking to see whether the tremor improves, you're looking to see whether the pain improves. There's a reliance on neurophysiological monitoring, and also again surgical adjuncts such as the operating robot here, which can be used to place actually EEG electrodes, for example, in epilepsy surgery. Trauma. Trauma is an interesting one. I think there's so much heterogeneity. There are so many interventions that patients with severe traumatic brain injury receive. All of those interventions are there to reduce the secondary injury. You can't do anything about the primary injury. You can't reverse the impact with the ground, but it's about reducing the impact of inflammation, of brain swelling, of excitotoxicity, etc. And so all and unlike other aspects of those individual interventions on an individual patient level. So I think most TBI neurosurgeons are quite interested in systems, are quite interested in groups of patients as a whole and how you can modify their outcomes. So it's, there's a strong overlap with clinical research and with improving trauma systems, for example, in major trauma centers. So policy that becomes a big part of it. The surgery in trauma surgery, to be honest, is mostly registrar-led operations, horrible situations, a massive epidural, lots of bleeding, lots of blood products, and it's TBI neurosurgery is very integrated with critical care of these patients. Moving on to spine, I think you can divide spine into intradural cases, and really the classical cases for intradural neurosurgery are meningiomas and schwannomas, which are outside the spinal cord, and then intramedullary tumours, astrocytomas, ependymomas. And the skills that are used in intradural spine surgery are really similar to those that are used in microscopic brain tumour surgery, for example. And that's the contrast with the other aspects of spine surgery or complex spine surgery, which is to do with mechanics, with biomechanics, to do with structure, so fixing fractures, stabilising the scaffold of the spine when it's been affected by tumours or degeneration. It's very tech heavy, a lot of equipment, very expensive. All scrub nurses, well, this is probably not true, but I think a lot of them hate big complex spine cases because all the kit that they have to carry is quite heavy. And then finally, my specialty, which is, or my kind of main specialty interest, which is pediatric care. And pediatric neurosurgery, you're really a generalist. So the biggest we deal with are CSF, so kids with hydrocephalus, kids with head injuries, and then brain tumor. But again, the types of brain tumors that we see, they're kind of mixed. You need a mixed skill base for them. Some will be skull-based tumors, so craniopharyngiomas, again, relying on that discernible anatomy that you can see, whereas others will be intrinsic tumors in the brain, again, relying on making those judgment calls using experience and intraoperative adjuncts to decide how much tumor to resect. In quaternary centres, so in the children's hospitals, in addition to these general paediatric cases, epilepsy and craniofacial, which are more super specialised aspects of paediatric neurosurgery, are also carried out. The big thing about paediatrics is that it's all about chronic disease management. So you put a shunt in a baby, an XPREM as an neonate, and you look after them for 18 years, or if you work in a combined adult centre, for their whole life. And so a lot of these patients with hydrocephalus, with tumours, will become chronic patients. You see them on an annual basis. The other thing about paediatric neurosurgery is that I think of all the specialties, it involves the most talking to patients, to colleagues, and the MDT is really vital. So I think with pediatrics, the adage holds that you can please some of the people all of the time, you can please all of the people some of the time, but you can't please all of the people all of the time. There's always so many discussions with the pediatric oncologists, with the neurologists, with the family, with the pediatricians. And so I think part of pediatric neurosurgery is navigating that aspect of communication. So that's a quick overview of the different specialties in neurosurgery, and you can see how they each have their own skill sets. But there is a lot of overlap, and so there are shared features of the neurosurgical subspecialties. I think all aspects of neurosurgery require learning. There is a learning curve with all of this. It takes a little while. Whatever you're doing, if you're starting off doing chronic subdurals as an SHO, to if you're doing complex midline tumours as a consultant, you probably won't have done many as a trainee. There's always a learning curve and a period where you need to develop the skills for different cases. MDT, so discussions with oncologists, with neurologists, with other colleagues who do neurosurgery is a big part of neurosurgery. So, and that really informs the preoperative decision-making and risk evaluation for patients. All of neurosurgery is overall 50-50 urgent and emergency care and elective care. There are big cases and there are small cases. So for example, with my specialty of pediatrics, it's quite nice to have the odd all-day case, a big tumor that takes all day. But also it's very nice to have a list with 3 or 4 cases of simple small cases, shunts and things like that, endoscopic third ventriculostomies. All neurosurgeons are physicians, and so with that, part of your job is advocacy for your patients, and sometimes that relates to competing agendas of your institution or colleagues. You're really trying to get your patient done on operating list, but you've got to speak to one of your colleagues to try and make space, etc. So you're advocates for your patient. As I've said, communication is a big part of all neurosurgery. You have to be able to communicate complex ideas to patients, to their relatives. You have to be able to guide them and support them in the decisions that they make. You have to obviously guide them and support them in the recovery from the operations that you do. So communication is a big part of neurosurgery. I think in terms of the operative aspects of neurosurgery, really all neurosurgery is a series of interruptive decisions. That's all surgery is. I think that's common to all surgical specialties. And so it requires a degree of decisiveness, not recklessness, but decisiveness, being able to take all these bits of information and use them to make interruptive decisions. And you're making decisions all the time. How do you position the patient? Do you have them lateral? Do you have them prone? Where do you put the pins? How do you set up the stealth image guidance in the theatre? How do you drape? Do you give some local anaesthetic? There are all these micro decisions that are informed by the clinical history, by your MDT discussion, by how the pre-op scan looks. There are interruptive decisions based on what the image guidance is telling you. We use interruptive ultrasound, and some places we use interruptive MRI, and that will inform your decision making. Maybe the anaesthetist tells you that the blood pressure is falling, there's been a lot of blood loss. That will inform your interruptive decision making. We regularly make use of interruptive neuromonitoring in some cases. Again, a real feature of all surgical specialties is the importance of anatomy to guide your interruptive decision making. And that's really important. And I suppose what I mean by anatomy is being able to understand in a 3D space, in a way, 2D concepts. We all learn anatomy from textbooks, and really the anatomy is the study of 3D objects' relationships to each other. And it's being able to conceptualize that in 3D and apply that to what you're doing is the kind of essence of surgery, really. Experience is a big part of your interruptive decision making. It's not unusual for us to, ask for help, to get colleagues to come and give their input. And to some extent, these two factors are relevant as well. So resources, you know, you can only do, you know, to some extent, you plan your whole list. You don't just look after individual patients, you look after groups of patients. So to some extent, your individual operative decision-making will partly depend on, for example, what else you've got on that list that day. And also it's important to recognize those negative kind of emotional states, fatigue, stress, that will have an impact on your intraoperative decision-making. So really, neurosurgery, the surgical aspect of it really is just a series of decisions, a series of micro decisions. As a consultant, you never stop being on call. Obviously, being on call is a big part of being a neurosurgical trainee. And you know, there are good bits and bad bits about being on call. Mostly bad bits, particularly as neurosurgery has such a high emergency load. A big part of neurosurgery is dealing with you know, emergency cases and all the aspects of that. So just to, I suppose, I thought I'd give you an overview of what my kind of day-to-day practice is like. So really, this is pretty much how my week went. In fact, this is pretty much how my week is going this week. So normally on a Monday, I probably get in for about to see what's been happening with the patients. Because I'm a relatively junior consultant, I'm still quite guilty sometimes of looking up on the patient notes at home, which is bad because you really should try and switch off when you're at home. We have a consultant meeting at 8:30 on a Monday where all the consultants gather, and usually we discuss, sometimes we discuss training issues, sometimes we discuss managerial issues, you know, bed state situation, theatre state situation, all of those issues that are relevant to the consultant body. I do a ward round often with my co-consultant colleagues. This is our specialist nurse and a couple of our trainees. And then I do a clinic every morning for a couple of hours, have a pediatric oncology MPT at lunchtime. And then usually in the afternoon, we'll do some admin. I think probably on average on a Monday, I'd leave work by about 6 o'clock in the evening. I have one of my things that I love to do, which the trainees hate, is I love to catch people sleeping in the MDT. And I'd like to shame them by taking their picture or video. They hate that, but it's just, you know, the MDT can be a little bit dull if you're not directly involved, but it's, as I've explained, it's a big part of neurosurgery. So on a Tuesday is usually my operating day. So I'd probably get in at about 7:30 just to quickly see the patients. If they're elective patients, they've usually been consented in clinic, but if not, then I quickly consent them in the morning, or one of the registrars would. We team brief in theatre at 8, usually send for the patient by 8:30. And then the list goes on for the whole day. This particular Tuesday, I was on call as well. So after theatre, catch up with the on-call registrar, or in fact the 2 registrars that are on during the day, just to go through the 20 or so referrals that have been referred, and to formulate plans. On a Wednesday, do a post-take ward round, handover at 7:30, and then a post-take ward round from 8. I have my adult clinic on a Wednesday, which for the last few months, for obvious reasons, has been mostly a virtual clinic done on the phone. And then dreaded admin. And usually on a Wednesday afternoon, I'll try and take the afternoon off, or do some other stuff. Just a note about admin. Again, this is a big part of neurosurgery as a consultant. Death by email. The administrative stuff that you have to do, you have to organise your theatre lists. That's been particularly challenging recently, because making sure they're isolated and have COVID swabs has particular challenges when you're trying to organise your list. Making sure that you can get the cases that you want to do on one particular list. Similarly with clinic, I have to preview my clinic to see which patients are suitable for telephone consultation and or face-to-face, seeing which patients on the NDT. Often there are emails about rota issues. I'm clinical supervisor for trainees, and that takes up a bit of administrative time. We all do a bit of teaching, both formally and informally. As a consultant, you often get asked to review particular standard operating procedures, protocols. I do, will often review my clinic letters in my admin time, review radiology reports. So every week I get a big folder from my secretary, which has lots of letters in from for the patient. So the one thing about pediatric neurosurgery, as I said, is about chronic disease management. So all of these patients are under pediatricians around the community. So every time a patient sneezes, I get copied into a letter about it. But you have to kind of go through those and just make sure that there's no other neurosurgical current issues. And it's similar with radiology reports, making sure that there's nothing that you've missed. Often we get asked to do police reports, and invariably, complaints and incident forms that you have to deal with. So admin is a really big part of the neurosurgical job. The nice thing about being a consultant, and to some extent a registrar, is that there are times you do have time to do other things. And one of my mentors always told me, you can't just do neurosurgery, you have to do 3 things, whether that be research, management, medical legal practice, some private practice, whether you're involved in innovation. This device here was designed by Richard Ashpole in Nottingham, who also designed the Rowena training headset that you might have come across. And he was really keen on innovation, on neurosurgical projects, and so that was his interest. Maybe you get involved in simulation, in teaching. So there is, opportunities, and most consultants they won't just do the clinical job. I mean, it's not essential, but most consultants will do something else. So on a Thursday, MDTs, spinal MDT, adult oncology MDT. Recently, I've been doing this from home, which is quite nice. Again, sometimes in theatre on a Thursday. We usually have a teaching rounds. So that's a big part of neurosurgery, is making sure that we're up to date, make sure that we have regular M&M, that we discuss our complications. So those things usually happen on a Thursday. On Friday, we'll usually have a theatre day, not always, but maybe every other Friday. So that's how a typical week looks for me. We're really lucky in Addenbrooke's that we've got our own kind of dedicated theatre suite, and there's a really good camaraderie amongst the theatre staff. And often on a Friday, there's some kind of, bring some food in. I never bring any food in, but I eat everybody else's. It really seems to mind at the moment. So that's kind of my week, what it involves as a pediatric neurosurgery, just to give you an overview of what neurosurgery involves. And then just for the final third bit of the talk, I just wanted to run through a few cases that I think demonstrate some of the kind of typical characteristics of neurosurgery as a specialty. So this is a spinal dysraphism case, a form of spina bifida. This is the preoperative MRI, and this is what we found intraoperatively. So the conus, or the distal ends of the spinal cord, ends low and is replaced by fat that comes through the dura. And then we removed the fat, and what we found was that actually it was a kind of split cord malformation of the conus, with one conus ending in the fat that went through the dura and the other part of the conus ending up in the phylum. And this case really is just to demonstrate that we get the scans pre-op, but really they don't tell you half the story. And one of the joys about neurosurgery is the creative aspects of it, and the fact that you really have to, in a way, make things up as you go along. I think some aspects of neurosurgery are akin to, bursting a spot. They're just kind of enjoyable in that sense. This isn't an epidermal tumor, and in a sense it is like a pimple, because it's cholesterol crystals, which are the same things that you get in a sebaceous cyst, really. This is the pre-op scan, and it's just picking away at this, which is just, it's just quite a satisfying thing to do. We do a lot of endoscopy in, and I always think endoscopy is a little bit like scuba diving, in the sense that when you scuba dive, it makes you feel like you're a non-disruptive member of marine life. And I think endoscopy makes you feel like you can have a non-destructive way of seeing into the brain. And so that's just enjoyable as well, if you're into that thing. Some cases can be really difficult and challenging. And so that you know, makes your life interesting. I mean, fortunately, these cases, you know, they're not that common. So this is a deep pineal tumor. So we come along the superior cerebellar surface and you get to the vein of Galen, which is here. So there's lots of important structures around there. And one of the aspects about this kind of surgery that makes it really difficult and challenging is that it's such a deep, long way in. And so I feel it's always like akin to, I don't know, dribbling a football or dribbling a basketball in between shelves on either side that are stacked with fragile and expensive vases. You just feel really nervous that there's all this stuff around you. So that's one aspect of neurosurgery, is that I think whatever level you're at, it can be, you know, it can be difficult and challenging sometimes. There are some things where you have to be delicate. So this is a Chiari case, just dissecting the tonsils away from the arachnoid. Where there are other aspects of neurosurgery where you need to be a little bit more rugged, and you know you're operating in a part of the brain that allows, you know, that is forgiving of you being a little bit rugged. This is a patient from a few weeks ago. So this is the preoperative scan showing a left-sided chronic subdural hematoma with a degree of midline shift. This is the post-operative scan, which looks worse than the preoperative scan. So the ventricle is completely compressed on this side. There's a bit of acute blood. You can see the drain in situ. This is a tumor, metastatic renal tumor that I operated on maybe 3 months ago. This is the post-op scan showing a relatively large extradural hematoma. So the other aspect of neurosurgery is complications. Complications will always happen. And it's one of the difficult aspects of neurosurgery, because sometimes those complications can be, you know, sometimes they can be fatal, sometimes they can be, have a huge impact on both the patients and their carers' quality of life going forward. So I think being able to always remain deeply analytical, not completely devoid of emotion when these things happen, because they are really depressing and stressful. But it is a high-risk specialty, and so it is part of neurosurgery. With that is litigation, is complaints. This is some litigation that I was involved in as a trainee, and again, neurosurgery is one of the specialties that attracts some of the highest litigation. I think on average, in this unit, each adult patient costs the hospital about £2,000, which is an average of all the costs for litigation spread over all the patients that we see. So litigation complaints are all a part of neurosurgery, unfortunately. Just the last bit of my talk. So I've talked about the different aspects of the subspecialties, what characterizes those. I've given you some kind of typical index cases and some cases that illustrate some of the aspects of neurosurgery that I think are unique to neurosurgery. But what about the people that do neurosurgery? What about their personalities? What about their characters? Well, I mean, I've had the honor, the joy to work with loads of different neurosurgeons in different unit, and you know, there is no defining characteristic. Neurosurgery attracts all sorts. There are introverts, there are extroverts, there are people that are really serious and glum, there are people that are really jokey and really happy. You know, there are people that are really socially awkward, maybe slightly on the spectrum. There are people that are the opposite to that. There are people that, you know, are really anal, you know, really particular about things, whereas there are other people that are seemingly not. So it really attracts a wide spectrum of different types of people. So I don't think there is one defining characteristic, apart from, you know, an enjoyment of the neurosciences, the clinical neurosciences, a degree of ability to be decisive when it counts. There aren't any really other characteristic features of a neurosurgeon. So just to kind of conclude, you know, the personal aspects to me of being a neurosurgeon, of what neurosurgery is to me, is that it's fun. You can probably tell from the pictures, particularly on the previous slide, that I really, really enjoy my job. I can't imagine doing anything else. I rarely kind of, struggle to get up in the morning to come into work. Part of that comes from the challenge, comes from the variability that you have in the week. It's extremely collaborative. All the opportunities to engage in research and innovation and teaching and earning a little bit more money are all great as a consultant. As I said, it can be really humbling at times, and it can be extremely painful at times, particularly when it comes to complications that you've caused. So what is neurosurgery? I think neurosurgery is a collaborative and enjoyable series of informed decisions communicated effectively to peers and patients, applied dexterously to the brain and spinal cord by interested and passionate clinical neuroscientist doctors. So that's my concluding definition of what is neurosurgery. Thank you all for listening. I'm going to turn my video back on and pass. Maybe I'll stop sharing and yeah, allow Ashwin just to share any questions that you've got.
All right, well, wow, what can I say? Thank you so much, Mr. Jalloh, for providing us with that roadmap to help navigate the sort of neurosurgical specialty in such an engaging way. Personally, I loved all the analogies, from recognizing the vascular streets of Tokyo to scuba diving through all the ventricular systems, and before you meet an untimely end under a burden of admin work. Yeah, thanks for providing us with both a realistic and inspiring talk for all of our viewers, and we're all immensely grateful for all of your time and efforts. Thank you so much.
Ashwin, I really appreciate it. It's been a real pleasure.
Pleasure, and thanks everyone for joining the talk. Take care, have a good evening.